Excuse me, Chair, it's Rachel from LPT. I've just had a message from Angela. She's waiting to be let in, please.
Right. No doubt Ewan will press the relevant button. Yeah. He's still there. Oh, yes, he is, yeah. Yeah. Right, I think the witching hour is here. Are we online yet, Ewan?
Yeah, we're online.
Okay. So welcome to today's meeting of the Leicestershire, Leicester and Rutland Health Overview and Scrutiny Committee, which is being held online using Microsoft Teams due to the current situation. When this meeting was arranged, none of us knew the unique circumstances in which Leicester and some of the surrounding suburbs would find themselves in today. As it happens, the first report today on our agenda concentrates on the coronavirus responses from our local NHS. I've also asked if there could be a statement at the beginning of that report by our Director of Public Health, Mike Sands, on as literally the up-to-date lockdown situation locally. Today's meeting is being broadcast live to the public on YouTube, so welcome to those tuning in today. And also for those who are not able to watch it live, the footage will be available on our archive after the meeting. Can I please ask that all officers and members mute their microphones until they are invited to speak. When you're speaking, please make sure your video is turned on as well, that we can see you. So I'll now go around and ask members to introduce themselves. And I understand as of about 5 minutes ago, there were no substitutes for today. And this, again, is part of the system that we use in order to ensure that we have a roll call, really. So I'll speak to you all in turn, if you can just say whether you're present or not, really. So I've got Councillor Aldred. No answer. Something's squeaking. Councillor Chamond.
Councillor Chamond sends her apologies because she's at work.
Thanks, Patrick. I've seen this name, Councillor Fonseca. I think I know you're here.
Yes, I'm there.
I've just seen you on my. You never know quite who's going to be on the screen, do you? Councillor Gillard. No, not heard him. I've seen Councillor Hack.
Yes, Kevin. I'm
Present, Chairman.
Yeah. Oh, thank you. Councillor Hill.
I'm here, Chair, thank you.
I know you're there. Councillor Kittrick, we just heard you, so I know you're there. Councillor March.
Hello, I'm here too. Morning.
Yeah, thanks, Melissa. Councillor Morgan, yes, you're on my screen.
Good morning, Chair.
And Councillor Sangster, yes, I can see you. Councillor Seaton. Interesting. Councillor Wright, I've seen you.
Yes, here, Chair. Thank you. Good morning.
Good morning. Councillor Westley.
Here, Chair. Morning.
Thank you. And then, well, there's Councillor Waller, of course, from Rutland.
Here, Chair. Good morning, everyone.
Morning. And Councillor Harvey, I've seen both of you.
Good morning.
And then we've got our two Health Watch representatives, is Michael Smith.
Yes, I'm here, Chair.
Thank you very much. And Janet Underwood, Dr. Underwood.
Yes, I'm here.
Thank you very much indeed. So that's where we are with all those. So we move actually onto the agenda now. So minutes of the meeting held on the 24th of January 2020. I'm proposing that the minutes of the meeting held on 24th of January are taken as read, confirmed and signed. Can I have an agreement from all of you, at least no one to disagree? Everyone okay?
Yeah.
So that's lovely. So question time from members of the public. We've received 6 questions from the public in total. Members, I hope, have all had a copy of them, and also the answers that have been provided by the various officers on my behalf. 4 of the questions were from Mrs. Jean Burbage. Mrs. Burbage, do you want to ask a supplementary question to any of your questions?
I'm not sure if Mrs. Burbage is still on the line. She's having some technical problems, so she may not be there anymore.
Okay, I'll move on to Two of the other two questions, rather, were from Mr. Robert Ball. Mr. Ball, I've seen you once, I know, on the screen. Do you want to ask a supplementary question?
I do, yes.
Thank you. Go ahead.
Right. This is on supplementary to question 6. For clarification, what percentage of the cancelled 700 non-urgent operations will be undertaken by the NHS, and what percentage will be undertaken by private providers if the backlog of non-urgent operations are to be cleared within the estimated 12 months?
Right.
Hi, it's Rebecca Brown here. Should I respond?
Yes, please. Yes, please.
Thank you, Mr. Ball. I don't have the actual percentage, but I will be able to come back to you on that once I have that from my colleagues. But what I can say is that the private providers, both the Nuffield and the Spire within Leicestershire, together with the Alliance, which is our system provider, that works outside of UHL, together with you in UHL, are working very, very closely to ensure that we get all the patients that we can treated appropriately in the most timely way that we can. So we're using all of our resources across all of those areas. So it could be UHL staff working in the private sector, or it could be the private sector working in the Alliance. We'll be working very closely together to ensure that everybody gets what they need during this very, very challenging time of restoration. But I'll be able to share that percentage, but it will be very broad percentage with Mr. Ball offline, if that's okay.
Right. Yeah. Thank you.
Is that okay? Thanks very much, Mr. Ball, for that. I think it's I mean, I think Rebecca said it exactly, didn't it? It is a challenging time, especially obviously for the NHS at the moment and all those trying to do the work with it. Do we know if Mrs. Burbage is back online at all yet? Ewan?
I can't see her, no, I'm afraid. We may have to move on.
Right, fair enough. But I mean, she's obviously had the answers to the questions she asked, but I think she did have a supplementary.
Yeah, her supplementary was something along the lines of just clarifying the numbers of real beds and whether it was refurbishments or not. But I'm afraid she was going to clarify the precise wording, and she's not here at the moment.
Yeah. Okay. Well, we might perhaps be able to get an answer to that. When we have that to actually get the proper question. Then item 3 on the agenda is questions asked by members under Standing Order 7.3 and 7.5 out of our Constitution. And we've received a question from Mrs. Amanda Hack. Again, the question and answer should have been shared with members. Mrs. Hack, do you have a supplementary?
No, I don't have a supplementary, Chair, but I just wanted to welcome the suggestion for agenda item for a future health scrutiny, whether that's joint or Leicestershire. I'm sure that can be decided. Thank you.
Well, that's lovely. Thank you very much indeed. So urgent items. I've not got no urgent items. Declaration of interest. Do any members have any interest to declare today's agenda? No, I see no hands raised. Presentation of petitions. We don't have any petitions today. So we're now onto item 7, which relates to the COVID-19 and the Leicestershire and Rutland NHS response. And I gather we've got Andy Williams here. We've got Rebecca Brown, and I think Angela, if she's managed to join us. But if not, I'm sure there'll be someone. But first of all, Mike Sands. Are you there, Mike?
Yes, I am, Chair.
Oh, well done. And Mike's very kindly, I just thought it was worthwhile at this point having something about it. He's the Director of Public Health here at Leicestershire, and I've asked him to give an introductory statement on where we are really with the Leicester situation as we are. So over to you, Mike.
Yeah. Thank you, Chair. I mean, much I could say, but I'll keep it brief because clearly there's an awful lot in the media that members will have seen as well. Suffice to say, I think things are moving at great pace. Obviously, members will be aware that a local lockdown was called for Leicester City and parts of the county that surrounds the city on Monday night. In terms of a response to that, clearly the City Council was leading an incident management team responding to the surge in numbers before the announcement of the lockdown. That incident management team is now led by Sue Ibbotson as Centre Director for the East and West Midlands of Public Health England, supported by my opposite number in the city, Ivan Brown, and myself. Underneath Sue, she has established a comprehensive structure to respond to this, which covers testing, support for those that need to self-isolate in the exclusion zone who maybe can't travel out to or otherwise get support. Issues obviously around community engagement and communications is a key part of the response to that, and various other cells linking in with care homes, education, really trying to deal with the plethora of things that need to be put in place and need to be supported. From my point of view, obviously this is a lot around the city and particularly the epicentre of the epidemic, but working closely with Sue and with city colleagues to make certain that we are providing resources alongside Public Health England and other organisations, and an immense amount of resource that's gone into the city, but also making certain that we are, if you like, making certain that our version, the bits of the lockdown zone that are in the county, are similarly, we're looking at the data, that we're doing the comms and engagement that we need to with our local communities. So I think that's looking, rapid pace, particularly at the start of the week, in terms of setting up a structure and bringing in this national resource. In terms of impact, of course, clearly it's a little bit too soon to see, but if you look on the BBC website, for instance, there is data for all upper tier local authorities, which talks about the number of cases per 100,000 in the last week. I think you can see that within the city, that case, although it's still an outlier compared to the rest of the country, at least that the numbers have stabilised and that things are not accelerating as they were. And from a county point of view, of course, there's been lots of conversations and talk around why are we included and why aren't we? But if you look at the data, yes, we have got significantly lower rate than the city, but compared to the national rates, it is still higher than I would want. So again, there is a message which I know is more personal to Leicestershire rather than L&R, which is, there is no room for complacency across the whole of Leicestershire, and particularly within those areas that bound to the city. So I'll kind of leave it along the lines of an immense amount of work that's gone in this week and indeed in the weeks before, led by my city opposite number. Signs already that hopefully things are beginning to work, but we need to keep the pressure on. And because this is, an imposition, I know, on people just when we were looking to come out, but we really do need to drive the virus out. And whether we like it or not, there is more in Leicestershire, not so much Rutland, than we would see in other parts of the country. If this was the southwest, we wouldn't be having this conversation, but we are where we are, unfortunately.
No, thanks very much, Mike. Now, I remember a couple of weeks ago when the Leicester thing first started, and I did ask you at the time, have we heard anything about Bradford? And I see they're now number 2 on the list. So yeah, it just shows, doesn't it? In fact, I was talking to my daughter the other day, because Bedford, I thought, leafy Bedford, nothing. They're 6th on the list. And then I looked for Rutland, and they're way, way down. So yeah, Rutland are obviously doing very well. Councillor Hack.
Thank you, Kevin, to bring me in at this point. Just for other members, I did put forward some questions rather than raise them under the emergency process. Kevin allowed me to ask them at this point. Mike's alluded to it a little bit in what he said. So just a couple of things really is obviously Leicester City Council at the point that I asked this had ward level data for those people who tested positive for COVID, pillar 1 and pillar 2. Have we had that same level of detail for Leicestershire and Rutland? And what is that data telling us? If you have any more information that we could elaborate on, that would be fabulous. Thank you. Would you like me to do all 3 questions, Kevin, or in between? Yeah. Okay, thank you. So obviously, this has already happened, but the electoral divisions that have been impacted by local lockdown have obviously now covered the city and the county. What preparations have been made with the district and the city to support those communities along the boundary as well as those in the city? And then finally, Leicestershire had previously been identified as a public health test and trace pilot area along with 10 others. How does this change the approach for the county in light of the local outbreak? Thank you.
Yeah. Thanks very much, Amanda. Is that okay, Mike? Are you okay to answer that?
That's fine. Yes. Thank you, Mrs. Hack. So the first bit, again, very well covered. So Like every other authority, we signed a data sharing agreement with PHE towards the back end of last week, 24th, 25th, 26th of June. So we've been receiving postcoded level data, full postcode level data on positive cases into the local authority. Leicester City Council obviously had the bespoke piece of work with PHE a week or two ago, which identified the particular hotspot. For us, we're mapping the cases across the county as we are for Leicestershire, as we are for Rutland as well. It get into a sort of data suppression argument, which I won't bore you with. So what I've got access to now are maps, not at individual electoral ward level data, because we haven't had as many cases in the county and Rutland as in the city. But we've certainly got it mapped down to what's called MSOA, middle super output area level, which again starts giving us a level of granularity around knowing where cases have been that we just haven't had up until now. So I could go on at length about what it tells us. I mean, what I would say is it builds on publicly available data, known for a while that cases, even on the limited data that's been in the public domain, have always been higher in areas such as Oby and Wigston and Hinckley Bosworth. Again, I wouldn't say that they are as high as the city, but the idea there is no room for complacency, I think, in Leicestershire more generally. Rutland, again, is in maybe a bit of a better place, is true. But the more granular data would suggest, it's not universal, that if you look at the areas of Leicestershire that surround the city, they tend to be associated with higher rates of infection than the ones that are further away. So if you compared Melton with Birstall, for instance, you'd see a clear difference between the two. We're just working on what level of detail and how we would put that and put it in the public domain, because I think at a certain level we can say a little bit more than we've been able to in the past. So the straight answer is yes, we're getting the data and we're mapping it, and we're using that again as part of the outbreak response. Second question around what preparations have been made with districts and cities. So again, this is all part of the incident management team approach. It builds on work. So I talked about the support for the shielded and the vulnerable, and clearly we've got a well-practiced routine across Leicestershire, Leicester City and Rutland about how we support those people who have been shielding, and we're using that to extend the support beyond the end of the shielding area for those that need to self-isolate. That, of course, draws in the districts, and there are all of the community hubs that have been part of the shielded work over the last 3 or 4 months. And then in terms of specific support for communities, I talked about shielded. Equally, from my point of view, if I think about Oby and Wigston, which is of course the only one of my districts that are in the lockdown zone, there is, as well as the focus on the city, there is the work that we need to do with communities in Oby and Wigston to make certain, as we all should, that we're aware of any issues there may be in observing social distancing and working with any particular communities that have found that difficult or maybe haven't heard messages in the past. And had a fruitful meeting with officers of Oby and Wigston Council yesterday. Again, not to overly worry Oby and Wigston, there are less cases there than Leicester City, but it is an area of concern. It is in the lockdown, and it makes sense to make certain that we are working closely with City, but following a bit of a twin track to make certain that we are supporting and working with our district colleagues to do the right thing and to get those messages out in the areas of the lockdown zone that surround the county. And then lastly, sorry, just to move on to the test and trace pilot area. It's not a time for humour, but I did make the joke when we were writing our outbreak plans that it was going to be like my approach to making IKEA furniture, which is you make it first and then you write the manual after. I didn't quite realise how prescient a comment that was going to be. So being part of the pilot, even before the announcement of the lockdown zone, meant that we were helping write the manual for the rest of the country on things like data sharing, the kind of data that every local authority would want to see, some of the governance bits, working with the other 10 pilot areas. We've very much been part of national conversations, testing the system. And then, of course, the experience of the last few weeks in Leicester has meant that we've got a lot more experience about what this means in operation. And if there's one thing I have learned is the outbreak plan initially was almost based along the lines of, we will have a meeting and we will look at the data and we will find out where the areas are and we'll find out what the issues are, and then we'll think about what actions we need to take and then we'll implement them. And clearly the experience, particularly over the last few days and the last couple of weeks, has been life is not like that when you've got a bubbling up of cases. You need to take action. very, very quickly in the way that City have done and that we're now doing in the broader lockdown area. So don't know if that really answers your question, but being part of the pilot has been an opportunity to shape it. And like everything, that's then being further shaped by the lived experience of going through what we're going through at the moment.
Is that okay, Amanda?
That's great. Thank you, Mike.
Councillor Waller.
Thank you, Chairman. Mike, you mentioned in what you were telling us earlier on about a communication strategy. Does that include providing information in the various community languages in Leicester?
Yes, again, I'm speaking on behalf of my opposite number, but I think one of the bits of learning that's really been stood up rapidly and is getting out there now is the need to make certain that the national message there have been and the local messages are freely available in all languages. So I think there's been a lot of learning about the need to get those messages out. I don't think it's just about translated materials. Part of a bigger conversation that we could have about all our communities, which is the best way of reaching out to people. We tend to talk about using mainstream media channels, BBC Local Radio, which is fantastic, the Mercury, we would always do that. But you know as well as I that people get their news, if they get their news at all, in many different ways. So looking at how we would use social media is one. And personally, I just really think there is no substitute for people on the ground, whether you call them community champions or community leaders, it doesn't matter, to actually do this face to face and door to door. And members know that very well, because you are, as well as elected members, you are community champions and community leaders. And I know you're all actively involved in getting those messages out there. So I think there's lots of learning from Leicester and from Bradford and other areas about the best way of communicating with diverse communities, however you describe diversity.
Thank you, Mike. That's an issue I want to come back to, Chairman, in a later agenda item, or a later part of the agenda.
Yeah, thanks very much. Michael Smith.
No, thank you, Chair. It's just really kind of touches on something that Mike was just also saying about. We've seen a lot of the literature coming out in different languages from Leicester City Council, and there's certainly been kind of sending that out through the communities. But there is a larger question around engaging with those different communities, and we are undertaking quite a big piece of work around how communities are engaged with and how that can be improved. Also just want to kind of highlight that this is all being done very digitally, and whilst I know that the City Council are trying to get leaflets out through people's letterboxes and out on the street, there is still, people are being missed, and there's also the people that are either digitally excluded, and you think about sensory deprivation and the implications of communication with people like that. So just need to be very kind of mindful, just as far as kind of who might be missed in some of the communication plans.
Yeah, thanks. That's a very good point. I'd also heard that some of the money that I gather is coming from government is specifically targeted at communication. So I thought clearly somewhere along the line, someone has obviously picked up the fact that there's a whole load of work that needs doing on it. Yeah, thanks very much, Michael. Jonathan.
And I'll mute myself. Thank you. Mike, a very quick question. Really good, interesting PhD document issued obviously a couple of days ago. Are we going to get an updated version that actually covers the actual lockdown area rather than just a part of it?
So probably two bits to this. I'm not aware of that sort of detailed report that PHE did. I'm not aware that there's any plans to go and replicate that initial rapid epidemiological investigation that they did that was published a couple of days ago. Again, I'm just thinking through what we can put in the public domain from our own data. But clearly, as I alluded to, we are able now, we're getting the source data directly to start doing the analysis, as I've just been talking to analyst colleagues this morning, in terms of cases over a 7-day or 14-day rolling basis on a much lower area than we've been able to share before. So that also covers issues around, for instance, the age and sex split, the gender split that the PHE reports also covered. I don't think we can do ethnicity in a way that the PHE report did. But again, I'm umming and erring a bit because I know we've got the data. It's just a question of to do with data suppression, and obviously you need to keep the numbers at an aggregate level so that people can be individually identified. But where we can do the analysis, we will.
I absolutely get the releasing postgate data is not acceptable, but ward by ward data, I suspect, is aggregated enough that it's not identifiable in any sense. So, like the
bit more than ward, but getting there.
Yeah, provides a story as to what's happening in the within the lockdown area itself.
Yeah, exactly. And I'd say that the initial bit is even looking on the BBC website today at the whole upper tier local authority data gives an indication of, I was trying to think how would one put it. It is not that Leicestershire is an area of concern in and of itself, but bearing in mind the overlaps that we've got with the city, then that's when you start looking at the figures. I don't want to call it a firebreaker as such, but the sense in my mind that there is potentially more tinder in the area surrounding the county and indeed the broader county, where if we don't take action now, it could catch fire, which is, from my point of view, I don't want us to be the start of a second wave.
Absolutely, and by the sounds of it, you are working on something to actually complement the what was done in the city in the county areas.
Absolutely, but ultimately, as I've always said, whether you're inside the red line or outside the red line, what you need to do is exactly the same. It's all incumbent on us to observe social distancing and to do the hand hygiene. It's the line is immaterial.
Absolutely agree with you. Absolutely agree with you. And have we got a timetable on when that's likely to be published?
The data, I'm just working on it now. As I say, just need to think about some kind of narrative or a format at which we can share it. But I could do with some of this. Obviously, we've only been getting this data for last week, and it makes more sense to get more numbers in because then you can tell a more accurate picture about what's going on.
Okay, thank you.
Thank you for that. One of the issues I think has been, which you have to be careful of, being in the past in this area, is sample size. If you're not too careful, you go right down to the ward level and you find there's only one person, and then everyone knows who it is. So you have to worry about that. Yeah.
And
sorry.
Go on. No, sorry.
Paul, Councillor Wesley, you're waving.
Use this technology, Chair. Having said that, what concerns me, we've had 2 local outbreaks within, you probably heard on the news, Walker's Crisps, Samworth Brothers. And I think it's important quick testing on them sites is delivered, because we have people travelling right the way across from all over, even the county, working in those factories.
That's right.
So they need to do a lot better and a lot quicker, Chair, to localise that outbreak, because otherwise it's going to spread into the county and further afield if quick action is not taken. Thank you.
So if I can just reply to that one again, as part of the instant management response, I know colleagues in Public Health England, supported by my team, others, and City Public Health colleagues, are working specifically on outbreaks that have been reported in actually sort of, not just food manufacturers, manufacturing more generally. There have been a number. I think some of the ones for me is, again, how shall I put it? There's a few things in my mind, one of which is when you talk about outbreaks, there's the temptation to say because it's been found in Samworth Brothers or Walkers that there is the source of the outbreak and it's going to spread from there into the community. I would suggest it's equally as likely, if not more so, that because they are big employers who look out for signs and symptoms, they're picking up stuff that is in the community and then it's showing in the factory. So again, I think it's important not to blame the source of the outbreak, because actually I think I'd sort of congratulate them on reporting them as they needed to. But it is symptomatic of there are parts of the community where there is still this kind of bubbling rate of infection that's then being picked up by employers. Noticeable that they are big employers, and I'd suggest again it's almost easier and better for big employers to recognise this because they have OCI health departments than maybe the smaller ones, where how would you know that there's not the case that people are working and coming into small employers? So I wouldn't want to beat up Samworths and Walkers as you suggested, because I think they're actually the measures they've put in place are by and large the right thing to do. There are issues we know about, which again is incumbent on all of us around our personal responsibility to make certain we're not doing things like accidentally car sharing and not taking appropriate measures like face masks and face coverings in car sharing and inadvertently transmitting it that way around. So workplaces is a specific area that we're looking at, and it is a little bit more complex than just saying there are outbreaks in factories. There's a whole load of things about direction of causality and the issues that we need to address that are not necessarily about what's going on inside plants like Walkers.
All right. Thanks, Mike.
Could I ask a question, please? I'm sorry, I don't have the hand to wave.
Who's that?
It's Janet Underwood.
Oh yeah, hello. Sorry.
Sorry, I didn't have the hand to wave.
Right.
There's two questions, please, if I could ask Mr. Sands. The first one is that on the BBC News website, they're saying that on the 1st of July, the infection rate per 100,000 for Leicester was 141.32. Merthyr Tydfil, 179.03. I've not heard anything anywhere that suggests Merthyr Tydfil should be taking similar precautions.
Yeah, I was just reading that as well. So I think Merthyr is up there. The thought that was in my mind, if you look at the difference from last week, it looks like they've had a spike in the last week, because I looked at the previous week's figures and they were really low. Yeah. So making up as I go along, but my thoughts in that one is I don't know if there's been a particular localized outbreak in a care home or another setting that's caused a rapid increase in a number of cases, whether if they're on top of that, it's a little bit like the Weston-super-Mare one. Is this about community transmission in Merthyr Tydfil, or is it localized to a particular area? But you know, I suppose it does go to show how quickly, if you measure things by rates, these things can blow up. And that's one of the things that I know we were there first, but we will see this in other places. You know, it's if things blow, they can blow quickly, and you need to get on and take action as quickly as you can. So it'd be interesting to see what the figures are like for Merthyr Tydfil next week.
Thank you. The second question is related to that, in that I've had a recent experience of test and trace. I eventually received my testing kit on the Saturday. It took me 2 days to be able to get through to log into the computer. It just wouldn't accept the code I was given. I then was told I'd got to do the test 2 hours before the courier came, but the courier was coming between 8 a.m. and 6 p.m. So that makes a nonsense. I was then given, we were then had to put the swab in a tube in a bag. The bag was heat sealed all the way around and wouldn't open. We then had to put that into a box. The instructions for the box were on the underside, and there were step-by-step instructions. So each time we got to the next step, we had to lift the box up to look at the next instruction, and the preceding instruction was undone in the lifting up of the box. And it took 9 days for me to get a result. I don't think this is satisfactory.
I wouldn't disagree. I mean, I've had similar stories since Test and Trace started. Clearly, there can be hiccups. Having said that, I think I heard yesterday it's something like 91% of people do get their test results within 24 hours and are very quick to get their tests. I mean, obviously, it's a little bit easier if you go through a drive-through rather than a home testing kit. So, I thought the situation in terms of home testing kits had got a lot better. Clearly, there can be delays. If you start adding up the delays that can occur if you're unlucky in terms of sending the kits out and then getting it done and then getting it processed, it can add to it. But it's not a infallible system. But equally, if you do look at the numbers of tests we're doing, it's clearly a lot better than where we were 2 months ago, and that's fed through for me, because that does mean I'm now getting the data that I need.
Could I just add to that coming from Rutland, we've had a mobile testing unit, I think twice for about 3 days at the beginning of each month. Other than that, people from Rutland have to drive all the way to Bristol, which, if you can't drive, is a problem. It's a problem if you need to go by public transport, because I wouldn't know how to get from the village I live in to Bristol. In fact, I don't know where Bristol is. If I had the infection and felt particularly ill, I don't think I would have risked driving, unlike Dominic Cummins. So I think that that the system is, my experience of it is the system is not working for people in Rutland.
Yeah, interested, you said Bristol. I've been for a test, but I went to a driving centre, and the one I was asked to go to was Peterborough, East of England showground, which is down the A1 from Rutland, isn't it? But yeah, as you say, it's still a matter of driving somewhere, isn't it?
It's further away from my part of Rutland, and as far as I know, there is no public transport from Rutland to the showground. You'd have to go into Peterborough and somehow find your way out again.
Yeah, which I can see therefore is why, as you say, you had a test kit for home, which is obviously the alternative. Yeah.
I do think the whole test and trace system is not working at optimum.
Yeah.
And I would be interested to know if anything could be done to improve it.
I think stories like you just related need to be putting together and aggregated, and obviously Mike's been listening to it, so hopefully that will get somewhere. Yeah,
I mean,
thank you very much for that.
And if you can just reply, I mean, again, I do think things have come on a lot since the days when, if you remember, the only regional site we had was the one in Boots in Nottingham. So now that we've got, we have got Birstall, that's been churning through a good number of sites per day, a good number of tests per day. Clearly, it's not convenient for everybody. The mobile testing units, so when they've been out to Rutland Showground, is a way of trying to get some more localized localized testing stations in place. It would be nice to do that more often. And again, some of the learning on the job experience that we've been able to do in Leicester is the ability to stand up these more localized testing stations. There's obviously been a lot of talk about Spinney Hills Park, but whether that's the right place and everything else, that's a different debate. But the ability to actually stand up something at short notice, if needed, if there was a particular surge in cases, is something that we've learned. So in terms of regular testing in Rutland, then we can always consider that as and when we get more capacity. But if there was anything that we needed to deploy to cope with a surge in cases in Rutland, we could do that pretty quickly.
Yeah, thanks. Maggie Wright. Maggie? She's gone off the radar.
I think she's got her microphone turned off.
You're on mute, Maggie.
No image. Yeah, not hearing you, Maggie.
Sorry.
There you go. Start again.
No, not working.
We can hear you now, Mrs. Wright.
Yeah, we can hear you.
Can you hear me?
Yeah, can now.
Sorry, I'm having awful problems with the technology. It's just not doing what I want it to do. It was a question, Mike, around the Pillar 1 and Pillar 2 statistics and data that's being bandied about. And I'm being asked a lot of questions from residents to explain it and try and say, well, what's the significant and what is any one pillar more essential than the other, or how does it work and how does it work together?
Yeah, thank you. God, I'm tempted to rub my hands with glee and go, I'll create a technical question about different pillars. Sit down, strap yourself in. This will take an hour. In short, the difference between Pillar 1 testing is the clinically prioritized testing. That's obviously been happening since the very start of testing, and it's prioritized on those who admitted to hospital, or when PHE go into a care home and investigate the first few cases to establish if there's been an outbreak. So clearly that's only ever going to be a snapshot of cases, because what that doesn't pick up is more kind of general community testing. It's always been useful to have that data, because it's the one thing where I can track a trend in time over time to see how things are going. So when you can follow it on the PHE dashboard, when we had anything up to about 180, 200 cases a week coming through on Pillar 1 testing over the Easter weekend. Now we are down to, I think it was 15 in the last week in Leicestershire. So if you look at the time series of comparing apples with apples, if you like, it tells you something around the overall spread of the virus. Then we, through test and trace and through the mobile testing unit, started standing up testing in other bits, home testing kits, as Janet has talked about, and the drive-throughs, the Birstalls of this world. And that clearly gives us a bigger picture of the number of positive cases that are out there in totality. So that gives, and this data is, I think, what is on the BBC website this morning, that data was now put on the PHE dashboard only as of yesterday, clearly gives the public a better feel for the actual number of cases that are out there. And as a rough rule of thumb, it's probably about the same number again in terms of cases in Pillar 2 as there is in Pillar 1. So it gives a more accurate spread of the spread of the virus. The other bit, and again, the Leicester City surge in cases is relevant to this, is Pillar 2, because it's not clinically prioritised, it's more likely to pick up people who are younger and haven't got such severe symptoms that they end up being admitted to hospital. So it probably gives you a better feel, like the age and sex data that I talked to with Mr. Morgan earlier on, for where things are at in the younger age group. So you do get a different profile of cases coming through Pillar 2 than you do in Pillar 1. So you need them both together. Pillar 1, I'm glad we had some data, but clearly Pillar 2, if you're trying to establish community spread and the actions you need to take, is the one that has started now coming through and really gives me a much better picture about what's going on in the community.
Yeah, thanks. Yeah, no, I can appreciate that. I keep following how many there are in the Harbour District, and for months it's been in the 170. It got to 176, I think. Yeah. And now it's gone to 357 overnight.
And it's exactly. And it's not that there, it's not that there's been a lie or a cover up. It's just the difference between the sort of clinical priorities and some of the hospital admission data would back that up versus being now able to say that was only ever a snapshot of cases. This is now something approaching a true picture.
Yeah, quite. No, it's better. Michael, I think you wanted to come back. Oh, and Paul.
Thank you, Chair. It was really just to kind of add an extra comment in relation to what seems to be a bit of a tension between the local messaging and the national messaging around kind of COVID-19. We're starting to hear more uncertainty about exactly what rules apply where. And I know that as I previously mentioned, we've seen a lot of the messaging coming out, but I think it might be beneficial in any community you choose to pick to have a bit of just clarification about what no longer applies in light of people needing to be much more stringent with taking precautions, so there's not people aren't thinking that they can't socially they can still meet in a garden as long as it's socially distant, or just how the national and the local are kind of how they align and how they can be a bit more clarified, really.
Yeah, thanks, Michael. I know comms colleagues are working on Q&A around what you can and can't do within the lockdown area, within the restricted zone. And again, more generally, I've got to worry for those parts, all the country, as we go into Super Saturday. Coming back to my point, it doesn't matter what the rules and regs are, that really this is in the hands of people to make certain that they, to quote Jonathan Van Tam's message at one of those ministerial briefings, they don't rip the pants out of the restrictions, because if you're in the area, you need to reserve the restrictions. If you're outside, I'd say you should still be observing them as closely as elsewhere. It is about personal responsibility, keeping away from people, wearing face coverings as appropriate. So what you can and what you can't do is important, and I know comms colleagues are working on clarifying that as much as we can. But the general message for me, in terms of what everybody else what we all need to do, remains the same, really, regardless.
Yeah, thank you very much. Paul, were you indicating you wanted to ask another question, because we want to move on?
Yeah, I wanted to come back, but obviously I don't want to take all your time up to mine. With these factories where you got local flare-ups, I don't necessarily agree with what you said. I'm sure all the factories are doing everything they can, but my residents are now worried and frightened that virus could spread into the community, because you got people there parking on the streets with their cars outside people's houses, and it's caused quite a lot of problems with the fear of infection. I'm just saying there's lessons we need to learn, Chair. And testing, obviously, now people are asking me, are we going to get tested if this is outbreaks? Because it's a very, very built up area. So I think we've got to be very quick, and we've got to learn the lessons, and we've got to support my residents. We're all in lockdown, and all we can do is tell them about the safety measures they have to take, but they're still not convinced.
Yeah. Well, thanks, Paul. I mean, you're right. I mean, obviously, take it up with your own, obviously with Ivan, but as you're obviously within the city. But I think, as I said, we really need to move on. We've got a lot of people waiting to give us their report. And the report is on the Leicestershire and Rutland NHS response to COVID-19. And I see we've got Andy, Rebecca, and I think Angela's around. Who's going to lead on this?
Chair, if it's okay, I'll lead off on behalf of the NHS family, and then obviously Rebecca and Angela will come in as well. So I thought I might just give you a brief overview and leave plenty of time for questions, if that was okay.
Yeah, that's fine, thanks.
Great. So I thank you for the opportunity just to kind of talk through with you where we've been with this. And I won't go through the paper because I know colleagues will have had that in advance. So I'll just use it as a framework, if you like, to structure some comments. A couple of things I think to say. First of all, I'd like to confirm really that we've worked as an NHS family in the wider sense, including our partners in the private sector, but also very importantly, our partners in local government as well, right from the beginning. And I think the level of partnership working and collaboration has been great, actually. So we are very grateful for that. And I hope colleagues would feel that we've reciprocated and worked well together. I think the second thing to say is that our response from a National Health Service perspective has largely centred on coping with the treatment of COVID. I mean, we've just spent quite a lot of time talking about the public health response to the management of communicable disease in the community. And of course, that is a public health lead, and colleagues from public health have been central to our work. But this report talks more about how we've responded to treating people who have COVID and the way in which we've ensured the capacity is available to make sure that we weren't overwhelmed at any point. And we did put in place extensive contingent capacity, and I'm pleased to say at no point has that capacity been exceeded. So initially there was a great concern that we would be overwhelmed, and I think we were very anxious about that possibility as a consequence of a combination of public policy, public health, people's own strict adherence actually to lockdown rules and social distancing, and the spatial data we saw from things like Google Maps and elsewhere showed that people in Leicester as a city and in Leicestershire and Rutland actually all adhered very well actually to those social distancing rules with noticeable drops in footfall. So this has been a complete societal level effort in which the NHS has played a part, but we've been grateful for the support of colleagues in doing that. The report details the practicalities. Principally, you could summarise us as by saying we've stood down a great deal of elective work to focus only on the most urgent of work, and of course to create capacity to deal with COVID-19 cases. That was particularly important in terms of acute illness. We have had some operational difficulties which are described in the paper, most particularly relating to supply chain issues around personal protective equipment. But despite the difficulties, we did overcome those, albeit some of them with quite expedient last-minute solutions. But at no point did we ever have to close a primary or secondary care service for the lack of availability of PPE. So it was a challenge, certainly put us under pressure, but we did get through that process. And again, there was a very evident partnership commitment to that. So we're pleased about that. Going forward, there are quite a lot of issues for us to focus on, I think, in terms of restart and recovery. And there's a real ambition, I think, to try, as well as to recommence services which we've had to inevitably delay. We're also keen, I think, to learn lessons, because our response to COVID and the relationship with partners has shown tremendous progress actually in facilitating discharge from hospital, in coordinating care across sectors and between different parts of the NHS, in the use of new technology to good effect, although I know people will have concerns about that, but there are considerable upsides to that as well. And in the coordination of care in key processes. So we're keen really to build on all of those things as we go forward. But we're also very keen to be realistic about the fact that we are in a situation for quite a long time, potentially, where we will be delivering care in a COVID environment where we have no cure, and we still don't, and where we have no vaccine, and we still don't. And so things like the focus on infection prevention and control, and the impacts that has on capacity will be profound, as well as, of course, of issues about public confidence and the ways in which we restart services. So those will take some considerable work together, and we're very keen to engage with you actively in that process. And we've already benefited from a very good partnership with Healthwatch to help us understand, public reactions to some of the changes that have been made. So I think I'd like to show and share with you, and I hope the report reflects a lot of very positive issues coming out of what's obviously been an exceptionally and quite extraordinarily challenging period of time. We're very sensitive to the fact that there's been considerable suffering and bereavement for people through this process, either directly as a consequence of their own experience or just the wider economic impacts or social impacts of lockdown. So it's difficult to get the balance right between being positive in terms of the things we've done without seeming glib about what's obviously been a very tragic human situation for many people. So this report tries to strike the balance. I hope you feel it's a candid exposition of what's gone on. It sets a scene for what will, I'm sure, be some questions. But I think our sense of it is, as an NHS, we've pulled together and delivered to a high standard, and we've certainly benefited from, and I believe we've contributed to, some really excellent partnership working in that time as well. So I'll pause there. Rebecca and Angela may wish to make some comments as well, and I've no doubt that there'll be a whole series of questions which we're obviously very happy to respond to.
Yes.
One or two, Crepine. Rebecca, Angela, is there anything you want to say?
Yes, if I could just add to what Andy said. I mean, I think that the other thing I'd want to convey is I think we're very, very proud of all of our staff across health and care, because this, as Andy said, has been unprecedented, and you all know that, but staff have gone absolutely beyond and above and continue to, not least in the recent outbreak and situation. I think we've seen staff be very flexible, they've risen to the challenge, and I think all of us would want to convey that to you and to put our record of thanks in relation to staff. Now, in relation to that, we also want to make sure our staff wellbeing remains central. So again, a lot of focus on that. And part of it will be looking at how we psychologically support staff who we know will be traumatised. And that's part of the work we're now looking at as to whether we do need to, in addition to the general awareness of psychological support, think about trauma services, because clearly we will need to think about how we can support people who will be impacted potentially now or in the future. So just to assure you all, that is something that we are also considering, because staff wellbeing will be very important to us. But as I say, we couldn't be prouder, and we have accelerated quite a lot of the elements that potentially were expected from us in terms of the long-term plan in relation to aspects like mental health. But we will be looking very closely at how the experience of people is in relation to those, so the digital elements that Andy's alluded to, and wanting to lock in benefits only where that is obviously effective. And if there are any changes that we want to bring forward, of course, we would be consulting and engaging appropriately in those. But as I say, very, very pleased, and would want to assure you that we are in a good place across the NHS family to support and continue this integrated work together.
Thank you very much, Angela. Rebecca, is there anything you want to say before?
Yeah, echoing very much the sentiment from Angela around our staff. I think that is a key. I'm very, very proud alongside Andy and Angela of how our teams have worked so brilliantly together, and seeing that again in the last week to make sure we're in the right position in readiness for another spike if that is to come. We are absolutely ready. But I also wanted just to reiterate that for all our staff, while we are seeing a downward trend to the actual numbers coming into the hospital now, remember what we are also doing is really hiking up the restoration and the recovery of our patients, so that we can make sure that those patients that need their operations are having them in a timely manner. So there is very little time for our staff to pause, because we have to be driving forward in the public interest. So this is a very challenging time. In some respects it's more challenging because you've got still got the COVID challenge, but you've got the non-COVID challenge, which is equally as big because those patients are as important. And we're trying to do 2 lots of work now to make sure we're in the best position that we can do.
All right, thank you very much indeed. I've so far got 6 questions on the thing. Councillor Waller.
Hello, sorry, my eyesight again. I've got a number of questions, Chairman. Do you want me to just ask one or go through them all?
Well, I am slightly worried that we've got another 5 or 6 after you as well. But obviously, but if they're all linked, clearly stick it all in one. But
I'll ask the first one, and then I'll put the hand up for the next one after everybody else has had a go.
Okay, thanks.
All right. Yes, and I'll reference the paragraph. It's paragraph 1.8 in the report. It talks about entering the recovery phase. Well, in light of what's happened in Leicester City, we in Rutland have been told that recovery has been abandoned and we're staying in full emergency mode. Are you moving towards your recovery, or are you having to put that on hold a bit because of Leicester, please?
So thank you. It's we talked about this morning. We have a regular weekly system level conversation about recovery, and obviously I can understand immediately why there would be concern, but I think it's really important to make 2 or 3 points here. First is we have and have always had and still have considerable contingent capacity in the NHS, and we've made sure that's the case. So we have been deliberately holding a capacity to deal with potential increases in COVID presentations. And to be clear, we are not currently seeing those. The demand on our services is relatively level. In fact, it's very slightly declining. If it does translate this spike in the city into increased demand, we can cope, but we're very conscious of the harm that might be arising from the delayed treatments for non-COVID related illness. And we took today, after a good considerable discussion and on the basis of all of the data we've had available to us, we took a very clear decision to continue the process of restart and recovery. We're being very careful about it. We're making sure that we're not contributing to potential cross-contamination or putting people or staff at risk. But there are legitimate things that we can restart, and we are restarting them in an attempt to minimize harm to people. So we'll try and get the communications on that very clear. We want to coordinate it very closely with public health messaging because we don't want to create a false sense of security to people in the city, where we're still saying very strongly that public health messaging is very important. But we are starting, and in Rutland and right across the piece actually, we are continuing with our restart process for the reasons I've described. So we'll do all that we can to be clear about that with people through our communications. But that's where we're at just at the moment, and the decision we've made literally within the last couple of hours. You know, this was hot off the press from this morning's conference call.
Thank you very much for that. I have to say, of all the complaints I've had as a county councillor since this has begun, not one has been about the NHS, so well done to you all.
Thank you, that's really nice to hear.
Sarah Hill.
Thank you, Chair. My question sort of looking really long term into the future. Given we've had this all kind of started with SARS in 2003, and we've had other sort of infections, this is the first one that's really had a massive impact on this country. What would you do differently if we, and when, I'll say when, because there will be another one, another novel disease comes up that puts pressure on the society as this has done? You know, we've had people, it is unprecedented, but I think it will happen again. So what are we, you know, what are you going to do differently next time is what I'm trying to say, government edict notwithstanding.
Should I come in there, Andy?
Please do.
Yeah, I think one of the things that we as health leaders have really reflect on over the last period of time is that data, making sure that we've got all the data together, that we've got, whether we're really triangulating that and able to look and see what's coming in the future, because then we can prepare appropriately. Throughout the pandemic situation that we've faced as a country, there's been some lack of transparency with some of the data due to many good reasons, and I think that's put us on a bit of a back foot. Within Leicestershire, we've been working really closely at how we can create a data cell that would be able to support us with the right clinical experts. We're now including academic experts, research experts, together with PHE and local PH, so that we now have a data cell that could really help us going forward, and a dashboard that we could be very responsive to. So that would be our key area, I think, if I was going to reflect on lessons learned.
Yeah, and if I can just add, I agree. I think that the ability for us to interface with public health and the wider public health elements, I think, is going to be pivotal. And if we think about what we've all learned through the COVID experience around health inequalities, this is going to be so important that we understand health inequalities in relation to health, and we understand that we are, shaping services and really looking at population health outcomes as opposed to services, which is the exciting part, I think, that we could all build on together.
Fair enough. Thank you very much. Melissa March.
Thank you, and thank you for the report. I've got a few questions too, Chair. My first question has kind of been answered already by Angela, and it was kind of about staff wellbeing and mental health, and I'm sure I'm not alone in being keen to kind of follow that as that progresses in the future. So my second question, Chair, excuse me, being a bit cheeky, is about PPE. And there's some suggestion in the report about difficulties and in the supply chain and working together, and all of which I completely understand. I guess my questions are, how did these challenges manifest themselves? Were staff always able to work, or were they did they have to stop work, or were they forced to work without PPE? And can we confidently say that staff in our NHS and our commissioned contracted out other services that aren't directly delivered by us, can we confidently say that people working in those and our services had the protection they needed to do their jobs at all times, please?
Thank you very much. Don't know which of you wants to answer that then.
I'm happy to say on PPE. So I think what was important to convey is that every organisation has what we call incident control centre, which was operational 7 days a week, remains 7 days a week now, and was tracking the PPE. So there was a really strong grip in terms of the PPE coming into any organisation. And regionally and nationally, that was also being led through the command and control structures. So whilst we describe PPE remaining and getting low, there was a lot of communication and mutual aid that supported people to get the PPE they needed. So for example, if UHL needed something, if we did, if other areas beyond us needed it, then there was a lot of connectivity at that time to make sure supplies were there. So there's a level of confidence that we didn't, as Andy said, I think earlier, that people had the PPE that was needed. And clearly we were active, very proactive, in fact, in terms of getting what we needed from whoever at that time. And I would want to commend regional colleagues who worked very hard with us actually to get that mutual aid. So that was important to us. So that would be my initial comment on it.
I think, if I might, I think one of the challenges was because this was a global pandemic and because it impacted across a whole series of nations simultaneously, what we were really seeing was actually a global supply chain issue with PPE. And this wasn't something where there was a problem in Leicester, but it was fine in Liverpool, or there was a problem in Wales, but it was okay in Scotland. This was a problem that affected the whole of the west of Europe all at once. And, everybody was trying to get the same kit from the same places. There were also issues in very practical terms about the fact that the source of a lot of PPE was from the Far East, which was subject to lockdown. So, you know, actually manufacturing was impacted by the kind of very processes that were trying to control the spread of the disease. So I think our local response was admirable and appropriate, and it was. You know, we worked really hard to make sure it was safe. The problem was that it exposed a global issue here about, you know, if you get a pandemic on this scale internationally, things that we take for granted, like global supply chain, actually become an issue. And I think there is some learning from there. But I wouldn't want you to feel that we're trying to be candid, I think, in saying, look, it was a real problem for us, but it was a problem we met. We did cope, but it was a struggle, and we had to work extremely hard to do so.
So can I
just come in just on one other point here, because I think, you know, we didn't cope alone. We had fantastic support from our system. So actually we had vets giving us their kit. We had private hospitals, private eye hospitals in Leicestershire supporting us with our kit. We had local schools developing and supporting us with visors. You know, we had businesses supporting us. So, you know, where we had times of real challenge, we had a system that came together so incredibly to support us, to ensure that every member of staff had the correct kit at any one time. And I can say from a hospital point of view, and I'm sure my colleagues would agree, we never let any of our staff down when it came to them having the right kit to do the right procedure.
Yeah. Thank you.
Thank you, Rebecca. I really appreciate that, and the confidence with which you state that. My question also asked about other people working in the NHS. For example, I know we contract out, for example, cleaning services and other things, so the private sector. Those people had the necessary PPE at all times as well, did they? Thank you.
Yeah, we were able to support all of our areas, and we, you know, those outside the NHS family, we also supported those when we needed to. We had one example of the prisons running short, and we supported them to ensure that they had the right kit.
Thank you very much.
Thank you.
Patrick, I think you're next.
Thank you very much. Just a few things. One, I read the report. Thank you very much for that. And I know it's one of these awful managerial phrases, but is there any chance of having, as it were, a service recovery dashboard? There you go. You can translate that into English. It's a case of, I think there's lots of information right across the operations of the health service that people are interested in, such as operations. You got some of it in the report, such as operations, waiting lists, backlogs of operations, GP surgery capacity, and it's all there. But from a scrutiny point of view, I'd quite like to see it all in one place, so we can see how services are coming back in quite an easily accessible way. You know, and as it were, the infamous dashboard. So first of all, is the work doing on that? Because some of the data is about COVID-19, but I think there needs to be a piece of work about what the capacity is, because the COVID-19 is the problem, the capacity, and getting that right is the solution. In terms of, there was some discussion about a switch over to online and phone services in order to conduct our business. And whilst a lot of that shifted and a lot of that is positive, what steps are we taking that those who are digitally excluded and struggle without face-to-face services, we had the earlier conversation about engagement with communities, that as it were doesn't take off, and that management, as people who are quite au fait with this, thinks everybody can access it when they clearly can't. And going on from that, there was a reference to some temporary service changes. Are there any of those changes that you'd seek to embed long term, which were adopted temporarily during the COVID-19 crisis? Just another couple of points. One, in particular, with the capacity at GP surgeries, before we know it, we will be on getting people jabs for the winter flu season, and this is going to be, it's most if we're going to get a serious second spike, it's most likely to come in the general flu season. Getting jabs administered is a huge logistical task anyway. What guarantees do we have about the administration of those jabs for this winter? And the final one, I'm not sure, and if it is going to be covered in the last agenda point, we can cover it then. But where does this leave the hospitals plan and assumptions made about how the NHS had worked before COVID-19, when we're going to have to re-examine all of those assumptions? Thank you very much, Chair.
Thanks, Patrick. Yeah, I'm sure you're right about that last item. I think that will come up in a few, half an hour or so.
That's fine.
Just to pick on one of those, would you mind if I asked John Edwards just to touch on some of the mental health aspects, because I think that would give you a sense of how we're trying to really look at what's working for people, the new opportunities, and it just give a flavour around that, if that's okay.
Yeah, Jonathan, John, isn't it? Yeah, John Edwards.
John. Hi. In line with the sort of national direction, we put in place, which is referred to in the document, a direct phone number that people can ring to get mental health support, and also what we've called a mental health urgent care hub, which has allowed, in effect, people that have come in through ambulances and police and the like to be transferred directly to a mental health facility away from the emergency department, which is again to support really in line with national direction, helping to keep emergency department as clear as possible. Both of those have evaluated really well so far, and seem to be extremely positive interventions to support the local population and partnership working. So we're working on the premise that these are things that probably would feature in our long-term thinking, and do line up well with the overall long-term plan that's promoted nationally as well. And we welcome the opportunity, probably in a future joint health and scrutiny committee, to come back and go through those, along with perhaps some of the other mental health changes that we've either put in place or learned that we need to put in place from this experience. So if you're welcome to that, we would welcome opportunity to come back perhaps to your next joint health review and scrutiny committee.
No, I think there's going to be a whole load of things that we're going to come back to.
Yeah.
Thanks very much for that, John.
Can I just pick up, Chair? There were a couple of wider points. The issue about recovery in a dashboard, I think, is well made. We've got quite detailed plans, which are good that they're there, but they're not very publicly understandable. And we've just been starting to think about how we can simplify and clarify that. So it would be good to share that with you. I think the recovery and restart agenda is one that we will need to talk to you a lot about, because this isn't going to be a simple process. COVID is going to be with us for a long time. Capacity is going to be very different from the way it was before. Views about what buildings can and can't be used for, and how they should and shouldn't be used, and what can and can't be done remotely, or public attitude to that, are going to change. Society's tolerance of digital is different. You know, people who would never have thought of using some of these things in the past now use it routinely, and for other people, of course, that simply heightens their level of exclusion. So we've got to be very careful to maintain a mixed economy. This is probably, I mean, COVID was a colossal challenge in a crisis sense. Restart is an even bigger challenge in a wider societal sense, because this will take us years. You know, literally, we are going to be working at this with you all the rest of this year, probably next year, and maybe even beyond. So I think it would be great, actually, and we're really keen to start a conversation with the elected executives of the councils. You know, this is something we need to plan and do together, and it's really challenging. So we absolutely will share where we're at, but I wouldn't want to create a sense that it's just a question of publishing some plans and getting on with it. I think there is a really big debate to be had between us all about how most effectively we go forward to something that is kind of post-COVID and positive. And there'll be great things about that, and there'll be some real challenges about that. And I think we need to work on them together as we go forward to make sure we take people with us, really.
Yeah, thanks, Andy. Okay with that, Patrick?
The GP flu jabs.
Yes.
Yeah, so sorry, I missed that. You're quite right to bring me back. So we've started the kind of planning for that early. We've got one of our local chairs, Professor Mayor Lakani, is coordinating that process. We're starting to think very carefully about how we get that capacity in place. I think we're very, very conscious of the need to have a good winter, if you know what I mean. And one of the things that I think will be interesting to see is whether or not the heightened sensitivity about communicable disease changes public attitude to immunisation and vaccination, actually. And we've typically done fairly well in vaccination terms, but we have consistently had some segments of the community that have been difficult to engage. So we're starting that planning early, and we're determined to try and make sure that we address this issue for exactly the reasons that the councillor was suggesting, really. So again, at a future point, you may wish us to share with you the planning work we're doing on the detail of that, but it is something we've begun already, if you like, even though we're months out yet from the time in which we would normally start that work.
Yeah, it's coming soon, you know. Amanda.
Thank you, Kevin. First of all, just to start off, to obviously pass on my thanks to all the colleagues in the NHS who've worked so hard over the last few months. This has obviously been a huge challenge, and I think that Leicestershire has adapted and coped really, really well. So thank you for that. First of all, just a comment. I really welcome the work that the team is looking at around mental health of the colleagues within the NHS. I think there was a report only a couple of weeks ago that indicated that mental health within NHS colleagues had already started to become something of a concern pre-COVID. So really welcome that work. Thank you. I think the thing that I just wanted to raise on mental health, though, was every single bit of communication I've had from the public since secondary lockdown, and my division is affected by the county boundary, is their overall impact on their mental health is that this freedom was given to them and taken away very quickly. And I think that I'm really actually concerned about the impact, how we communicate the data, what sits behind it, why county areas have selected, why some haven't. And I think more has to be put out there, because to identify it's areas of 10,000 or more really isn't good. I think we need to back that up with data, because that is of real concern to me. However, my question is around testing. It was something that I raised at the all-member briefing sessions we have at County Council on Tuesday. Testing, what is our position on testing with our local NHS colleagues and care staff? We know that Parliament rejected weekly testing, but I didn't know what the picture was in terms of regularity of our colleagues testing within our NHS services and beyond. Thank you.
So, I don't want to answer that.
So I think I can start, but I think it might be helpful to get some detail about the way this is actually working in service delivery, and I'm sure Angela and Rebecca will want to come in on that. I think as a local service, our focus was on the Pillar 1 testing you've heard described. That was our kind of initial remit and responsibility, and the establishment of wider testing was a kind of a national initiative. One wasn't subject to local control. I think we were very clear and had called actually quite openly for a more assertive approach to testing and for the sharing of that data more widely, and that certainly would have helped. And I'm sure those are sentiments that Mike will echo and that Ivan would echo if you were here. So I think the position on testing now is it's improved considerably. There's far greater availability of testing than when we began, and all of us were locally raising concerns about the volume and level of testing and the level of response. Going forward, I think probably having a more robust approach to testing and sharing of data is, for the reasons colleagues have said, that one of the key learning things that's come out of this process. But in terms of the detailed position for staff, that might be more appropriate for Angela and Rebecca to just comment on.
Yeah, go on, Rebecca.
Okay, just so you know, the pathology services in UHL, I think have done us really proud. For Leicestershire, we've been able to support not just our own Leicestershire NHS family, but the wider social services and also other providers such as in Northamptonshire. So we've been able to work a lot around the patient testing, the staff testing and the staff antigen testing. So again, we've been able to be a very flight of foot, making sure that we can, where we can, move forward. There has been, of course, during the pandemic, a period of time where we didn't get all the antigen that we needed to do the test. So we had to really look at how we did those differently. And the teams in UHL, in the pathology departments, work together to create a different format to do testing overnight, testing it and retesting it to make sure it's accurate. So again, you know, it just showed what we could do when we worked together. The staff testing is something that we want to really promote more within Leicestershire. We want to have the weekly or the bi-weekly testing. We had a big conversation about that this morning with our clinical colleagues, feeling very strongly that it should be bi-weekly test, not a weekly test for all staff, particularly those working in vulnerable areas. And we're looking to work out how we can provide that, probably through Pillar 2 rather than Pillar 1, because Pillar 1 is really it's more focused on the symptomatic areas and our patient turnaround. Because it's really important that we get that quick turnaround of results, particularly in the acute and in the LPT hospitals, because we need to be able to make decision making as quickly as possible so that we can ensure patients are in the right place.
Yeah,
thank you.
I think just to add, and again to give us some assurances that there are very clear processes for any staff member who develops symptoms or needs to access testing. So there's a real level of confidence now in relation to that. And just to give you a sense of it in terms of numbers, so for LPT, people who are absent from work, if you like, and this is just as of yesterday's position, is in the order of about 448, but that is only 223 that are related to COVID. So again, the numbers have come down, which is important to convey, but the important thing will be about how do we now, as Rebecca's alluded to, start to get testing for asymptomatic and the mass testing that we're going to need and the sort of repeated testing that we're going to need to remain confident, when that's something that I'm sure Leicestershire will be developing and others will need to follow.
Yeah, no, I agree. I mean, one anecdote I have is I have a friend whose baby had symptoms, fever, I think. Took them, they lived in Nottingham, so took them to their local testing centre, fine. The father who took the baby actually is an anaesthetist in Nottingham Health. And he said, well, can I have a test as well? No. And I think that's half the problem. You know, I mean, at the moment, particularly people who are right at the sharp end, we need to be sure that they are absolutely tested and we know what's going on. That's part of the issue, isn't it? Paul Westley, I think you were waving at me a while ago. Paul, are you around? No. I think we're probably, in that case, back to Councillor Weller.
Thank you very much, Chairman. I think I'll make a few observations before asking a very specific point, but our NHS colleagues may wish to comment on my observations. The first is related to the figures at A&E. Yes, they've gone down during this crisis, but prior to the crisis, we were very, very worried that people were presenting to A&E who shouldn't have been. They should have been going to their GPs or a pharmacist or whatever. And I think going forward, and I do very much welcome the comments that we will be involved in the planning for the future. One of the things that we need to do, I would suggest, is look at how we get a message out to people that you go to A&E when you need to, but if you don't need to, don't, if you see what I mean. So I think that's something I thought reading the paper occurred to me. The second was about the urgent care centres. A number have been temporarily closed. Now, I suspect that our health colleagues will be reviewing those going forward, but it seems, looking at the ones that are open, that for those of us who live on the periphery of the LLR area, we are the ones who are suffering, who won't have the access to the urgent care centres because of where they're located. So I'm wondering if you might want to comment on that. My final observation is about communication, which we have touched on. And I still think, and this is something that I've mentioned on more than one occasion in this forum, that our health colleagues aren't taking the opportunities that are out there to communicate with our public. Now, as councillors, we've all been having regular briefings from our chief execs and leading officers. And very many of us have then taken those briefings, synthesised the key messages and put them out through our village Facebook pages, websites, etc., etc. I keep a paper copy of everything and all my own notes after events. And I went through my paper copies of the NHS briefings that I've received following COVID. And I realised I've probably only had 3 or 4 of them, but there were many more than that because they are all numbered. Now, I don't know why I've not received all the others, but I can tell you that some of the messages in them I've put out to my own community. Around dentists, for example, I remember writing about on one occasion. So really, I think the channels that are there, the NHS just isn't using as well as it could. So that's my final observation. And my actual question is around PPE. We all know when COVID started, we started getting a lot of cottage industries making scrubs. Somebody I know contacted chief execs in the region, not just Rutland, because he had access to a factory that produced the appropriate material for making the gowns as well. But what he didn't know was what quality, in technically what quality was needed. And this particular factory made the material in a number of grades. So he didn't want to order the material in to get the people he knew who were making to make them without knowing that. All he ever got was go on the government supplier site and that will deal with it, which he did, but never, ever got a response. And he became very disillusioned because he could have provided a lot. So it's going forward, if we have another spike and another problem, are we absolutely confident that the supply chains are working, particularly given Andy's comments about them all being global? Thank you.
Thanks, Councillor.
Is it okay if I come in around the ED observation? Because I think that's a really important point.
Right.
And I think, you know, how we, as the Leicester and Rutland population use our accident and emergency department is really important as we go forward, particularly in the winter. And I think there's some great positive lessons that we can learn from the current situation. So what we have been able to do is support the public to choose more wisely in their approach. So at first we saw a lot of people frightened to use the hospital. And we don't want that. That is not the right approach. We want people, if they are poorly, we need to see them and we need to see them timely. But as the pandemic has gone on and Leicestershire public have recognised that, you know, they're sort of getting much more confidence in the system, we are seeing that the right patients are coming to us. So the hospital currently sees at the moment the same total numbers that they would expect to see of those major patients. That's really positive because it's telling me the right people are coming to hospital. But what we're not seeing is those people that really shouldn't have come to us who were choosing to come to us because it was a good, quick service, or they couldn't navigate the system. But actually, I think the measures that we put in place as the NHS family have really helped that, so that people are having a better response from 111, they're having a better response from local the hubs that we put in place. So it's meant that actually we're using our urgent and emergency departments so much more wisely. And if you look at some of the data that we're seeing there around ambulance handovers, etc., because this was a real concern for us. You know, we are now upper quartile in our ambulance handovers, even though we're still seeing that high numbers of ambulances coming in, you know, the biggest in the region currently. So, you know, I think those wonderful positive lessons that we've learned, we need to be working together to really keep those where we can in place. And that education of our public is very, very important with that.
Yeah.
And I would add, if I could just link that, the earlier point we had on the mental health that John was talking about, mental health urgent care hub and the central access points, these are things that we believe have had a positive effect and have supported the ED department, and of course supported people getting access in a very timely, effective way. So these will be things that we will want to talk to you about in the future, because as you rightly say, Councillor Waller, these are very important that we collectively work together to get the ED servicing the right people and getting the right people to the right place at the right time.
No, thanks for that. I've got Melissa March. Do you want to come back with a query?
Thank you, Chair. And I guess mine's an enduring concern that I have. And in a couple of the reports, there's phrases like we commissioned support from the independent sector and stuff. Whilst I'm prepared to accept in a time of national crisis, we absolutely want private involvement in our public services. I guess I find it much harder as we return back to normal. I'm keen to understand the scale of that and how that's worked, and I guess also the relative costs associated with that. Has that cost us more, for example, than doing things in-house? And are there some things that we'd like to bring back in-house that we've been working, you know, with the private sector to do? I guess I'm trying to dig into that area of our interaction with the private sector in all three, the UHL, the LPT and the CCG's work, please. Thank you.
Yes. So if I'm going to start just to say, in terms of the independent sector, we very much worked together. And we looked at it as part of what do we need collectively, whether it's UHL, LPT, across the board. And Rachel Bilsbury, who's on the line, was a cell lead, so not an LPT lead, but a cell lead in relation to this. So I'm going to ask Rachel to come in, and then we can add anything else if that doesn't clarify everything. Yep. Thanks, Rachel.
Thank you, Angela. Yes, thank you, Councillor March. So in relation to the independent sector nationally, there was a national contract that secured all independent sector capacity to support the NHS during the COVID period. And there was flexibility in that national contract to allow systems to determine how best they would want to use that capacity, dependent upon priorities in particular systems. Our system, our initial system priority, as Andy has already described, was to ensure that we had sufficient bed-based capacity to support flow from UHL for step-down patients to enable the expected surge to be supported in the acute setting. So our first priority was to work closely with the independent sector to convert what is ordinarily an elective service into a rehabilitation and subacute step-down service. I cannot thank our independent sector partner colleagues enough. They worked with us splendidly, really quickly to operationalise that model. And very shortly we had 33 beds in the Nuffield up and ready to go. As it happened, the number of people that we ended up transferring into those beds was very low because the anticipated surge didn't play out as we expected. Notwithstanding that, we've retained that flexibility with those partners. Again, as Andy has alluded to, we are very mindful and being very cautious about any further spikes or second waves. And so we have retained that flexibility to switch back should we need to. Rebecca might want to comment about the longer term and pre-COVID use of the independent sector. They have always supported the LLR health economy with a level of elective work, and again have picked up some of the high priority activity that Rebecca has alluded to ensure that they are working with us as partners to make sure people who need urgent elective surgery are able to be supported by the system. I don't know if there's anything else you want to say, Rebecca, in that respect.
Thanks, Rachel. And, you know, I have to say, Rachel has been an absolute NHS hero over the work that she did in this cell. So I will use this opportunity to say that because it was not easy, particularly when we did not know the scale of what we were going to encounter. So what we are really focusing on with our private providers is how can we ensure that we're getting the right care for the right group of patients that need it. So they have been working with us to see what is it that they're good at that we can exploit, and particularly around our cancer patients. So they've been doing a lot of our diagnostic work, supporting in imaging and other such diagnostic works, which has been really important for us. They have undertaken some of the cancer elective work, and we really want to see them during this next 12 months as part of the NHS family. They are being financed nationally as part of the national COVID money of how this is being done. And so there is not anything about making money from this. This is about us all working together and using the right resource to do the right cohort of patients. So at the moment, they're helping with that type of work. We are going to be working as we move on. We've got a sort of a scale of things that they're going to be doing. They're going to be doing some orthopedic work, some of the more basic 52-week wait work for us. But again, it's very much seen as how can we use all of our resources within the NHS Leicestershire as best as we can, and that includes these wonderful hospitals. And so we will continue to do that, and we will hopefully continue to do that till the end of April.
And finally, just to cover your point about the costs, all costs were covered by the national contract arrangement. So the system hasn't been required to fund that arrangement. It's been covered through the national contract arrangements.
Can I just say, I said the end of April, I meant to the end of March, end of the financial year.
Yeah.
Okay. Thank you. I think it kind of ties into some of the ongoing conversations, you know, that our immediate priority was beds. And then when we talk about, you know, in times gone by, reconfiguring our hospitals, we keep being told we don't need that many more beds for the next 40 years. So I've parked that for our future conversations as we go on to discuss that. And I hear what you're saying and think there's a need to use all the resources available to us at the moment. But I hope that in time from April 2021 going forward, we can find ways to find the right care for the right patients at the right time within the NHS. Thank you.
All right, thank you very much. Patrick, I've got you down as wanting another point.
No, I must have accidentally pressed the button. So.
Oh, all right. It happens to the best of us. I think that's about all I've got, actually. Yes, it is. So thank you very much, the colleagues from the NHS. You've fielded that lot well, and I'm sure there's plenty more that we can think of afterwards, but very helpful indeed. And as I've said right at the start, I'm sure much of this will lead to further things. I mean, of course, none of us were alive the last time we had a major worldwide pandemic back in 1918 with the flu pandemic. I suspect, like a lot of these things, this will be go down in history as a major pandemic, and of course it is. But you know, it's where we learn from it, isn't it, and how we go forward and make things better. Right, item 8. Next item relates to the prior year adjustment to UHL trust accounts. That's on pages 33 to 36 of your pack. And I gather Jonathan Shooter, I know you've been there all along, Deputy Chief Financial Officer, you're ready to tell us about this.
Jonathan, before you come in, if I just give a very high level introduction, and then I will then pass over to Jonathan. Yeah. So firstly, this is a very challenging situation for University Hospitals of Leicester. It's a situation that we're taking extremely seriously. It first came clear in late December, and we've been working through to really fully understand the scale and the reasons why we're in this position. We don't have at this stage the finalised report, so we're not able to answer questions on that. But what I am very pleased to say is since January, even with the pandemic, the Trust Board agreed that we needed to maintain and really push forward a focus on a financial recovery, and undertook a number of actions to ensure that we were working to improve our position and improve our governance very, very closely. And we worked again, hand in hand with our colleagues, both Andy and Angela, who are still on the call. So whilst this is not a position we would want to find ourselves in, we are absolutely grabbing it, and we are going to make sure that as we go forward, we are in the best position that we can be, recognising that this will have some regulatory oversight, and we need to be working within that once the report has been agreed. So I will then hand over to Jonathan. Thank you.
Thank you very much, Rebecca.
So just to add to Rebecca's comment overview, just really to add, as Rebecca said, we're clearly taking this very seriously and working through the position now with the Trust's external auditors, Grant Thornton. So you can see the paper summarises the position we are reporting pre the finalisation of that audit. So as it clearly says, a deficit of 84.1 million, excluding ESS or FNM funding. So, and that position being after a prior year adjustment of £46.2 million. And really the prior year adjustment is the nub of the detailed work we've been doing and also are now doing with our external auditors. And what that reflects is clearly an under-reporting of expenditure, but also an over-reporting of income previously that we've now worked through in a very detailed way through the Trust balance sheet. And obviously it's a very serious issue that we are working through with Grant Thornton on a daily basis to look at those transactions in absolute detail, to subsequently then conclude the audit and then report that position through the Trust regulators, NHSE and I think it is important though that we, as Rebecca said, that we focus, whilst we're doing that, we also focus on the future. And the report summarises the critical things we're doing around improving our financial governance and our financial controls. Really importantly, the culture and training and development of key colleagues throughout the Trust. So not only the finance team and the executive team, but also colleagues throughout the Trust in terms of financial discipline and how we move forward to ensure we're sustainable from a financial perspective. So that's the critical thing once we conclude the audit, that we work through to the future. So we're absolutely supporting patient care delivery with the best financial footing that we can do, knowing that that's always challenging around NHS finances, but it's critical that we do that in the best and the optimum way moving forward. So I think that's all I wanted to say to summarise where we are, but obviously happy to take any questions. Together with the report, the summary report, you can also see that we've presented our detailed financial report, but I don't think if there's any questions around the detailed report, I think I'm happy to sort of present the summary and then receive any questions.
Thank you very much. Patrick, you're first.
Thank you very much. Just a few questions. At this early stage, does it appear that it was a one-year accountancy problem, or that there are systemic issues with reporting? So is it a one-off or is it systemic? Secondly, you referred to Grant Thornton, but the report also refers to PricewaterhouseCoopers. So are Grant Thornton our current auditors? And if so, when does when you have a problem like this, the first question really you have to ask is, what were our current auditors doing? So we can clarify what that is. Looking at the report about leadership and delivery, I'm not intimately acquainted with the members of the University Hospitals board, but isn't it usual when you have appointments of non-execs that there is somebody with a financial background, at least one person with a financial background, who can give an independent financial overview? And do you think that it's got capacity? I'm not being funny. You say training about awareness of financial issues. Usually you've got somebody in with a background in accountancy or complex finance who would give you that lay point of view. In terms of looking at it, there's a phrase where it says that there is outturn for accruals, annual leave carry forward and working time directive holiday pay, which doesn't appear to be within the remit of this over-reporting of income and over-reporting of expenditure. Is that likely to significantly deteriorate the situation, as it were? Is it going to get worse than 46.2 million? And the final one, which probably is the most important question of all, is do we anticipate any real-world consequences of this prior year adjustment? As it were, is it just moving numbers round on a balance sheet, or can we expect fines imposed by government, and will savings have to be made in order to address this prior year adjustment? Thank you very much, Chair. It's quite a lot of questions, but as you can imagine, it's quite a subject.
Yep. So answer that, Jonathan. Yeah.
Rebecca, do you want me to start off on the first question around systemic? I'm guessing you might want to come in on some of the other points around board capability, accounting knowledge.
Yeah.
So if I just pick up the first question, I think the question was, is this a systemic issue in more than 1 year? So absolutely, it's more than 1 year. And as part of the work we did, we're taking a look back at prior years. So it's more than 1 year's adjustment. From a technical accounting or submission point of view, we go back 2 years as well as the financial year we report, and that's part of the submission we will be making in terms of adjusting to prior years. I think the second question was around, if my interpretation was it correct, around Grant Thornton. So Grant Thornton were the auditors last year, and clearly this process does challenge or ask some questions around around Grant Thornton's role or delivery within this process. I think it challenges all stakeholders within the values we're reporting. I think the third question was around board capability, and I think the specific was the knowledge or the qualification of an accountant on the board. So absolutely, an NHS board, as all boards would have an accounting expertise or a qualified accountant on the board, or a number of colleagues, make more than one. But clearly that does also, as I said previously, challenge all stakeholders in the process around not just, the board's role within this process is clearly challenged as well, as all stakeholders are. There's clearly a challenge as well to finance in terms of how we report the information to make it easy for all board holders to interpret. I think the next question was around, are we anticipating the position to get worse or more than £46 million? Well, every indication in terms of the PwC review and the Grant Thornton process that we're currently going through is that figure won't increase. I mean, clearly that's subject to the final audit, but every indication at the moment is that number won't increase beyond 46 million. I think the final question was around consequences, wasn't it? And it referred to fines. I think clearly we won't have fines in terms of an outcome, but what we would expect is increased oversight by the regulator. through as we move forward. But with that oversight also comes some support, but absolutely increased oversight as we move forward to make all the improvements that are outlined or summarised in the report. There was also a point to think about sustainability and in terms of improving the position as we move forward. And that is critical, actually, that we improve our financial sustainability. And the way we'll do that is to drive efficiencies forward. And we're actively working on that by the appointment of an external partner to drive and improve our financial performance as we move forward. I think that was all of the questions. I think Rebecca may want to come in on some of the points or some of my responses.
Yeah, thanks.
Thanks, Jonathan. If I could just add that while Grant Thornton is our external auditor, we had PwC, which was a regulatory appointment to investigate, so we could really understand and learn from what has happened over the past 3 years. So that's why they're both being talked about as it stands at the moment. Around the sustainable changes, we always knew we had an underlying deficit, and we've been working as a system to understand what that is. Of course, some of that is around recognising the need for our reconfiguration. As you know, we need to have a much more sustainable pathways of care that can and affordable. And we've been working through those as a system, and we're going to continue to work through those. But there, you know, let's not underestimate that extra regulatory scrutiny will make us really look at ourselves. What can we do differently? How can we do that? But the improvement element is also very important. So it's recognised that this is not all stick. There has to be carrot. There has to be support, because you know we need to strengthen our board. We need to strengthen the areas of weakness that we had. We have to strengthen the area within our finance department. But we also have to make sure that you know, culturally we look at the way that we manage finance in a very different way. We want to build on the work that we've done around our quality strategy and the stuff that we've been able to really take forward as a hospital, but also as a system, and use that same approach. So what we're currently looking at is absolutely building our quality strategy and putting finance and really around effectiveness and efficiency of pathways alongside that process. So in the next 12 months to 2 years, we'll be running those programs alongside each other. We will have the external support. We will also have some private support to give us, because around, again, some of this is around the capacity. We have to recognise we are also currently still within a pandemic. So we've got an awful lot of work to do on that front. So we need some support from a capacity point of view to help us go through this very, very difficult process and difficult year.
Can I just quickly come back very quickly? Can I just confirm, I think I picked it up, that you're going back 3 years, the PwC work. Can I just also check, I mean, I'm quite sceptical about the setup of audit in the United Kingdom. We are having we have got proper separation between Grant Thornton and PwC in this review. I know that the answer will be yes, but I've got to double check because I said I'm sceptical about the audit process. And finally, just to press on the real life implications of it, does this have implications? I believe the government said that it was looking to wipe hospitals' historic debts, and indeed the hospital's plan, should it go ahead in some form. Will this cause difficulties in either of those developments?
So if I just start, and then I'll ask Jonathan to come in around the debt, because I think that is a bit of a minefield of understanding the detail of that. So just from recognising the numbers and making sure we're really clear on those numbers, we have got a new finance director, Simon Lazarus, who's an interim person working with us on a fixed term. We are very hopeful that he will continue to stay with us. we've got Jonathan, who is a new appointment as a Deputy Director of Finance. They together, when they came in, identified the scale of what they were seeing, you know, with their looking at the balance sheet, the number that they actually came up together. That has been reinforced by PwC and Grant Thornton. So I think we are in a place, because we've got this new expertise in the hospital. I think we've got much better understanding of what that figure is, and being clear that, you know, we're not expecting it to move out greatly, and having the two different people looking in on us and really focusing on us has absolutely reinforced what we have to learn, what we have to do differently, but also the figure that we're seeing is, you know, we're quite confident that is the correct figure. Jonathan, do you want to just talk about the NHS debt from part?
Yeah, so what we're talking around now, or the prior period adjustment, won't impact on that change. So I think that change was made public a few months ago. That won't be impacted on by this process, so that'll still happen for the trust.
Mm.
Okay.
Yeah. Thank you very much. Melissa, did you want to ask a question? I'm not sure whether it was your previous hand up or this new hand.
Sorry, Chair, it is a new hand. You'll be all be pleased to know that Councillor Kitterick's asked most of my questions. So I've only got one remaining on this item, which is that in the report, I noticed that trust group holdings is referred to regularly, and including that there's multiple millions of pounds that are owed by UHL to trust group holdings. Can I ask, what is this trust group holdings, and what relationship does UHL have with them, including individual members of the board, please?
Mm.
Jonathan, will you take this forward, please?
So yeah, so the trust group holdings is a wholly owned subsidiary of the trust, from a pharmacy perspective. So I'm not sure, Rebecca, when it was created. I think it was 2 or 3 years ago. So it's a recent subsidiary of the trust that's been in operation for 2 or 3 years. So the second question was around the relationship of the board members to.
Yeah, sorry, I muted myself. And then it takes a while to unmute, doesn't it? So just to clarify, UHL owns Trust Group Holdings.
That's right, yeah.
Yeah.
Great. Okay, and then my second question was what is less relevant now, but it was about what relationship we have with them, because I had assumed wrongly that it was a private company, so I'm glad to hear that. But individual members of the board and officers have with that, but I guess it's clearer now.
Yeah, it's still
there's no
relevant.
conflict.
No, I mean, I think there's 2 board members on the UHL board that are also members of the TGH board, but they declare that interest on an ongoing basis. So I think that's the interim CFO and the chair of the finance committee are also on the TGH board, but they declare that as an ongoing interest.
But those interests, they can't be pecuniary financial, can they? They're just.
No,
okay.
Yeah.
Thank you.
Thank you. I've got Samantha Harvey a minute, but just before we do, I've actually also had just a message that Mark Whiteman, who was going to speak on the next paper, he's got to be off somewhere at 12. Rebecca, are you okay to take the next paper if Mark goes?
Sorry, I'm on mute. Let me just have a quick. I can just take while we're talking through this. Yeah. I can talk through with Mark, because I do believe he will. If we can move swiftly on, he will be able to stay and support. If we could just move on to that agenda item as soon as possible.
Okay, with just 2 more questions. Okay, Samantha Harvey then.
Thank you, Chair.
I've just got a couple of questions on the financial outline part of the paper. I was wondering whether there was any time frame at all for the PwC review. And it also does talk about a scheduled date for the next paper being the 4th of June. And I was wondering when we might get sight of that. And then I've just got a couple of questions about the numbers, if that would be all right.
I said we need to keep moving, but anyway, Jonathan, do you want to respond to that first bit?
So I think the first question was around the timing of the PwC review. Rebecca may need to come in here. My understanding is that's currently in draft format and is in the process of being finalised. I'm not sure on the exact timing, but Rebecca may know that.
Yeah.
So because it's not our report, we're not in a position where we can sort of push and drive when it will be available or if what part of it will be available. But what I do know is there's going to be a number of recommendations that will come with the report. And I would like to be able to, once we've got those agreed, those recommendations become a big part of our recovery programme, and that I would like to share those widely with everybody, and we can work through those recommendations and making sure that we're delivering those.
Yeah, thank you very much. Samantha.
So the next question, wasn't it, was I think the next question was the sharing of the 4th of June report. Because that will be a public trust board report, it will be shared on the trust website, available for the public.
Yeah, quite. The other points you're going to make, Samantha?
Oh yes, sorry. It was just a couple on the numbers really. They refer to the March 2020 key facts. We had kind of patient income, and it was just a question regarding what the pandemic and what obviously that as the cash receipts from car parking and things going down has had on the cash position. And then it was just maybe a clarity on the executive summary on the capital. Which financial year were we talking about in the capital box, the 49.6 million spend to date?
And then one of the things around the COVID expenditure, I think that's something that we could cover in quite a lot of detail when we next come back.
I agree.
Because it's very broad, it's a really big agenda item, and we could really explore that in detail, because it's very different now than it will be in the future as well, and we're just getting some clarity on that. So if you would be happy, we could use that. We talk about it a lot more in the next agenda item.
Yeah, no, yeah, that's fair enough.
Next time.
Yeah, I mean, we are talking about the prior year adjustments, not the current year. Yeah, quite.
Just on the question around the capital, so the report refers to 2019-20, so the last financial year. So all of what we're discussing is 2019-20.
That's right.
Thank you. And my only other question, and it has been kind of glanced on previously, was the overriding question was what obviously the issue, what it might have moving forward, looking towards the kind of rearrangement of services, building and stuff, and the trust's ability to raise additional funding in future.
If I come in initially, and Rebecca, I think, would want to comment, I don't think it has a long-term impact on our ability to reconfigure services and receive the funding that's been announced. I think clearly, though, as I referred to before, it's incumbent upon the trust to fundamentally make sure we improve our financial sustainability and continue to deliver the absolute best level of patient care with the most efficient financial delivery. So, but it doesn't refrain our ability to raise that money or receive that money as we move forward.
Yeah, no, thank you. Anything to add,
Yeah,
Rebecca?
I mean, I would just echo that. You know, this is a really important point for Leicestershire, Leicester and Rutland. You know, we need the capital investment that we need, that we know that we've been working for. We've been really working hard, and I'm confident with the conversations I've had with the national and the regional team that we will receive and be able to work through that once the appropriate time has come. So I'm confident that will still come to us, and we'll still be able to really drive forward the efficiencies and the new pathways that we need within our new hospital buildings.
Yeah, thank you very much. Right, well, thank you. That seems to be, we've come to the end of the questions on that particular item. So I'd like to move on then to item 9, which I gather is an update for us anyway on the UHL acute and maternity reconfiguration. Rebecca or Mark,
yeah,
whoever's.
I'm going to pass it straight on to Mark, because I want to make sure we use his time wisely. Yes. So it's straight to you, Mark.
Okay, I'll start with an apology. So Councillor March has said that these meetings are important, and I absolutely get that. But they were put into our diaries for a couple of hours, and therefore my PA, as an example, seems to think that I'm paid on like a piecemeal basis and crams the diary with as much as possible. So it's not trying to duck out, it's just recognising that we've got other stuff as well. So reconfiguration, I presume there's kind of 2 parts to this. First off, have we heard yet about whether we're going to get the check, such as it is? And the answer to that is no, not yet. Don't look shocked. I mean, we haven't. What I mean is, there's no kind of signature in blue ink on a £500 million worth of investment. To be honest, as Rebecca has already alluded to in a previous part of the discussion, that is not causing us too much anxiety, because all the signs are that it's a matter of when rather than if. But I think probably understandably, the top of the house in terms of the NHS, both on the political side and also on the officer side, have had a few other things on their plates recently, and certainly in terms of how they've allocated capital and the capital decisions they've been making, they've been focusing on capital that's been dedicated and devoted to COVID response. But as you have probably heard through media and other outlets, there is still a strong drive by the government to help the economy move out of what is likely to be quite a severe recession by investments in capital, both in schools and the health service and other parts of the public sector, all of which we take as good signs that actually the £500 million worth of investment for Leicester, Leicestershire and Rutland is still on the cards. So it's a bit of a mug's game at the moment, given the way that the world is kind of shaping up to make predictions. But we are planning for, rather than an August start for consultation on the reconfiguration plans, we're penciling it in for a definite maybe in September. But as I say, the starting gun really has to be fired yet. So that's in terms of our take on when we will hear. In the meantime, we're not sitting back twiddling our thumbs. There's at least as much work to do that has already been done in terms of our reconfiguration plans. And I would imagine that councillors will probably want to understand what our thoughts are in terms of the reconfiguration plans and what we've learned during this pandemic experience. So if I assume that's the case and just go into that for a second, and then I'm happy to take questions. So COVID, I've kind of described as a bit of an eclipse moment for the NHS. And what I mean by that is that those of you who are maybe kind of part-time astronomers will know that during an eclipse, astronomers around the world point their telescopes at the sun, because they know that actually during an eclipse it reveals things that are previously unseen. And the same thing has happened in the NHS, really. The COVID pandemic has been an eclipse moment, has revealed things that have previously been unseen in the NHS, like our ability to change at pace on things that previously have taken us years to achieve. And there's probably no better example than the way that primary care and secondary care has adapted to new technologies in order to keep seeing patients, albeit not by moving that patient's geography, i.e. getting people from Rutland to have to take a day and a half off almost, to come in for a 5 or 10 minute outpatient appointment that tells them they're well and we'll see them in 6 months' time. So that has been really, in one sense, exhilarating. I wish it hadn't happened as a result of a pandemic, but it's shown what the NHS can achieve. In terms of the reconfiguration itself, now probably 8 weeks, maybe 10 weeks ago, so probably around the peak of the pandemic, we asked our clinical teams in the hospital and further afield, essentially, hold on, knowing what we know now, what do you think of the reconfiguration plans? So we took that as an example to our clinical cabinet, which is a kind of multidisciplinary team of our clinical leaders and clinicians in the wider sense, so OTs, physios, nurses, doctors, surgeons, etc. And they put their slides all over the reconfiguration plans and had a really interesting debate that actually, if you remind yourselves what we're seeking to achieve through reconfiguration, it is essentially a doubling of our ITU capacity to create 2 super ITUs, so to move from a steady state of 50 ITU slots to 100 and something ITU slots. We wanted to create a children's standalone hospital in what is currently the Kensington building. We want to build a treatment centre, which is essentially an elective hospital within a hospital, almost like a third site within a second site, to do all the elective non-emergency patients. What the clinical teams came back with was, well, first off, in terms of having two kind of super ITUs, so doubling our ITU capacity from 50 to 100 would have been very handy during the pandemic. Part of the reason we're using the private sector is not because we're short of beds, it's because we've converted through peak a lot of the operating theatres into kind of makeshift ITUs because they have piped gases and air and other technology that we need. And our current ITUs, as councillors will know, are just not big enough for the population we serve. At the same time, and another reason why we're using the independent sector so extensively at the moment, is a lot of those people who were previously theatre practitioners working in operating theatres on, for example, elective hips and knees patients, we converted over a period of 3 weeks by supplementary training into being able to manage ventilated patients who had severe COVID breathing problems. So all of that contributed to us thinking, actually, you know what, if COVID had happened 4 years down the line, we could have probably soaked up most of that ITU capacity because we got to about 87 patients at our peak ventilated on ITU. So on the ITU element, 2 super ITUs would have been very handy during COVID. As regards the Children's Hospital, which is one of the other kind of signal parts of the reconfiguration plans, councillor colleagues might know that, and again, it goes back to ITU capacity, we shipped out, essentially, we transferred all of our children's heart surgery, reminding ourselves that we fought very hard to keep that service in LLR. We shipped it all out to Birmingham at the start of the pandemic. And the reason we did that was we needed to create as much adult ITU capacity to deal with those patients who are most affected by COVID, recognising that COVID, thank goodness, didn't affect our children quite as much as it did our adults. So the very difficult decision we made was to protect the surgery and make sure surgeries still happened. We would send it temporarily to Birmingham where it could take place in a standalone children's hospital, recognising we didn't have one. We've now repatriated it back, which is good, and the Children's Paediatric Intensive Care Unit is now back to doing children's cases, including children's heart cases. Have we had the reconfiguration monies and done the reconfiguration and created a standalone children's hospital, we wouldn't have had to do that. We could have kept our children's heart service running throughout the pandemic. So that's the other advantage of the reconfiguration. Last, but no, not last, nearly last, but not least, we should think about the treatment centre. So we've been spending all hours trying to work out how we run COVID and how we run COVID clean and COVID contaminated, as in two different patient streams in the recovery of our services. And at the moment, you will know that one of the problems that we have in UHL is that emergency and elective surgery and services and beds and wards sit alongside one another, which means that when we are full of emergency patients, the electives sadly get taken down and cancelled because we have to prioritise emergencies, which should be the case. If we had the treatment centre, then a lot of that elective work which we took down, we could have kept going, because the treatment centre would be at the Glenfield, but ring fence and protected in a standalone building that wouldn't have had any contamination issues by being part or sitting cheek by jowl with other emergency flows. And given what's happened to the waiting lists in the recent, 3 months, that would have been a real fillip to both our patients and our staff. We would have been able to bounce back an awful lot quicker. The last thing I'll say, Chair, and then I'll shut up and take questions, is we were running through peak of pandemic with something in the region of 20% staff sickness. Some of it was COVID related. Our staff were infected. Some of it was because they were shielding, and some of it because their people in their household were infected, and therefore they were 14 days self-isolating. But when 1 in 5 of your staff is down and you're trying to run rotas at 3 hospital sites, that was really very difficult. And when people like Angela and Andy and Rebecca at the top of this agenda were saying thank you to our staff, that's part of the reason. At UHL, they have done extraordinary things to keep services going whilst being stretched even more than they normally are, trying to keep 3 sites in operation. And so a lot of our, not least on ITU, a lot of our ITU consultants are saying, we just need to get this consolidation done, because if there is another pandemic, we can't expect that kind of thing to be, we can't ask the same thing again of our staff. But in summary, what I'm saying is we're pretty confident, in fact, we're damned confident that the money is still forthcoming, and it's just a matter of people's attention at the top of the house. It's probably been on other things recently. And in terms of the reconfiguration, the big building blocks actually would have served us better had we reconfigured at the time, by the time COVID hit. That doesn't mean that actually we won't be looking at, for example, the numbers of single rooms, things like air exchanges in single rooms and decontamination units. But broadly, the big building blocks would have been very handy had we reconfigured.
Yeah. Thank you very much, Mark. Gail Waller.
Thank you very much, Chairman. And thank you for staying to talk to us, Mark. We all understand the pressures you're under. I think the last point that you made was actually, in a way, the most interesting for me. And that is, yes, we all understand that COVID has brought into stark relief the inadequacies of the sites you're operating in. But it's also raised some other issues for you. So I think in light of that, we will all welcome you coming back, or your colleagues coming back, to talk a bit more thoroughly about all of this when consultation is formally happening. But I have a very specific, and it relates to the minutes of the last meeting, in fact. When we were talking about this sort of issue, there was a suggestion that you'd produce a briefing document for the public, which summarised what was already in the public domain. And I may have missed it, but I actually haven't seen such a document. Now, I do accept that there was no commitment to do it, that it was just under consideration. So it may be that you've decided not to, but I wonder if you could comment on that.
Yes, I can, Councillor. So I remember the conversation, even though January feels like an awful long time ago. And I think between myself and my colleague in the CCGs, we did say that we would do that, a kind of pull together of the current reconfiguration plans in an easy read format. I've got to put my hand up. Actually, events have washed both that memory and that duty away. So we'll get back onto it.
Thank you. May I come back on that
Yeah,
very briefly. Thanks. Thank you for your candour there, much appreciated. Can I suggest when you do pull it all together that you reflect the learning from COVID in it as well? I'm not saying necessarily that you put a lot of information, but at least
You've gone on
to mute, Gail.
Yeah.
Oh, I do apologise. Shall I try again? That when you do put the document together, that you reflect on your thinking as a result of COVID. And I'm not necessarily saying you put a load of extra information in and create work for yourself, but that you reflect that what you're pulling together is historic and it may change as a result of COVID because you are learning as a result of COVID, so that the public generally understand it's a moving feast, to use that horrible expression.
Yeah.
Thank you. That was all.
No, thanks, Councillor. No, I mean, I think the very fact that, as Mark mentioned, there were a number of instances where during the COVID pandemic, if the reconfiguration had already happened, it would have actually, some of the aspects would have got easier. So I think that's very valid, worth incorporating, isn't it? I have no other questions on the system. So I'm happy to say thank you very much to Mark, particularly, for hanging around. I'm sorry about that. And to all the others that have been presenting to us today, Rebecca and Angela and Andy and so on. We are due to have our next joint meeting at some indeterminate stage. I think probably September, is it? But anyway, really grateful to all those that managed to join us today, those that stayed to the end. And thank you very much. And really, really grateful. I think it's, we're obviously in totally unique times. And the very fact that we've been able to have such a good, frank, open discussion today, I think is very excellent for the working relationship between all of us. So thank you very much.
Can I just come in?
Yeah, sure.
We don't have a joint HOSC meeting arranged for the next one yet, mainly because I know a lot of the local authorities are having their annual council meetings at the moment, and there may be new members of the committee, etc. So I'm going to wait until I know who the new members of the joint HOSC are for the 2020-21 year, and then I'll be in touch with everybody to arrange something.
Thank you very much indeed. No, thanks very much. Very good point. Yes, quite. Okay, well, thank you very much, everybody, and it's time for lunch. Bye.
Thank you.